symposium. So kindly be seated, please. Chairman for this session is Professor Asad Aslam Khan, who was the dearest student of Professor Munirul Haq, and the co-chair is Professor Tayyab, who was the Azad student of Professor Munirul Haq. Moderator is Dr. Sidra. Is she here? चलें प्रोफेसर तैयब आप है शुरू करा दें प्लीज सेशन.
Bismillahirrahmanirrahim. We are holding this session in the memory of our beloved teacher, Professor Muhammad Mirul Haq Sahab. He was a legend in ophthalmology. He was known as giant orbital surgeon, along with one of the giant orbital surgeon from USA, Professor Brody. So these two was always called as giants of orbital surgery. So he has won the largest series of orbital lesions in the world, and he attended numerous international centers to learn orbital surgery, and he replicated whatever he learned abroad to Pakistan at Institute of Ophthalmology, Mayo Hospital. And he read a paper on orbit almost in each and every international conference as far as I know. So this is in memory of our late Professor Muhammad Mirul Haq Sahab. Sayyid Sahab, if you want to add something.
Well, nothing. I think myself and Professor Asad were his students, and we learned whatever we are doing now in orbital surgery is because of we dedicated to Professor Munirul Haq, late Professor Munirul Haq, and he was considered the father of orbital surgery in Pakistan. And Alhamdulillah, now he was only one of the very few in the country. Now we have a couple of people who are practicing orbital surgery across the country, and his students are really illuminating and enlightening his name. So today, because of the earlier session delay, one of our speakers, the first speaker, Dr. Samira Irfan, had to apologize and regret she has to go because she has one of her own instruction course on myopia, and it is on the other side of the conference hall. So she won't be taking part. So may I request so
I request Professor Tayyab Afani Sahab to talk about spectrum of orbital lymphoproliferative disorder.
I will be talking about the ocular adnexal lymphomas, and ocular adnexal lymphomas means lymphoproliferative disorders involving the eyelids, conjunctiva, and orbit. But let me emphasize here that most of our, the cases which will be including in this study are actually orbital and conjunctival in combination. So it is actually it's orbital series. So these ocular adnexal lymphoma constitutes less than 1% of all non-Hodgkin lymphomas and 5 to 15% of the extranodal cases. And most of these are B cell type. Diagnosis is a combination of histopathological, immunophenotypic, and molecular genetic information. Well, we have to ask 3 questions. Is the lesion malignant, transitional, for example, atypical reactive lymphoid hyperplasia, or benign reactive lymphoid hyperplasia, or what specific type of OL is present? And can specific prognostic features be identified? This is a retrospective analysis of 1,500 space-occupying lesions of orbit in last 25 years at Al-Shifa Trust Eye Hospital, Rawalpindi. Based on the 5th edition of WHO classification of hematolymphoid tumors, 148 lesions were identified. So in nutshell, 10% of our orbital SOLs in Pakistan may be hemolymphoid tumors.
Dr. Samira.
Results. So these were the lesions which we saw in last 25 years. This is a main category. I will also show you subcategories. So commonest is B cell lymphoid proliferations and lymphomas, which were about 129. And second, others were T cell were only 2 cases. Stroma divide neoplasm of lymphoid tissues were 2. Histiocytic dendritic cell neoplasm 13, and genetic tumor syndromes were 2. So overall 148 cases of OALs in the last 25 years, out of which, and you will see that 97 were females and 51 were males, which is 97 were males. So this is a marked male predominance in our series, which is a bit different from the rest of the studies, most of the studies elsewhere. So then further sub-classification as B cell lymphoid proliferations were further subdivided into these 3 categories: tumor-like lesions and precursors B cell neoplasm and mature B cell neoplasm. These are cases which we saw. I am not just giving you a theoretical workup, but these are the cases which we saw. Reactive lymphoid hyperplasia, IgG4 related orbital disease, Kesselman disease, these are the tumor-like lesions. And then precursor B cell neoplasm was only there are 2 cases, and most of the cases were mature B cell neoplasms, which include small cell, marginal zone, follicular, mantle cell lymphoma, diffuse large B cell lymphoma or DLBCL, and large B cell lymphomas and Burkitt lymphoma. So these were the cases which belong to the B cell lymphoid proliferations. The other T cell cases, there were 2 cases as I mentioned earlier: T cell lymphoblastic lymphoma, stroma-derived neoplasm on lymphoid tissues were myofibroblastic tumor, 2 cases, and histiocytic dendritic cell neoplasm of juvenile xanthogranuloma, Erdheim-Chester disease, Rosai-Dorfman, and Langerhans cell histiocytosis, and genetic tumor syndromes were Fanconi's anemia. Salient presenting features in all these cases were age range is the very wide age range. We have as much as early as up to 2 years, less than rather 2 years to 100 years was the case. The patients which are included in the study, the average age was 45 to 60 years. Very significant male predominance, as I mentioned earlier, and dystopia, diplopia, visible palpable mass are the usual presentations. Bilateral at the time of presentation in only 10% of cases, and systemic involvement was also in 10% of the cases at the time of presentation. And as you have seen, mature B cell lymphomas comprise the majority. Management is, of course, most important thing is appropriate, accurate diagnosis, which needs histopathology. Histopathology means biopsy, and immunohistochemistry, gene testing, and extensive systemic workup is very important. Treatment is, of course, these are the lines on which we have treated our cases: surgery, chemotherapy, immunotherapy, and radiation. And let me also share here that at Al Shifa Trust Eye Hospital, we have established a Center for Eye Cancer where we are ourselves providing oncology services, chemotherapy, radiation, and all this immunotherapy. All patients which we need these adjuvant therapies, they are treated at Al Shifa Trust Eye Hospital. Only a few cases are referred elsewhere. Adjuvant therapies which we have used, and this is from my medical oncologist who has shared her input. For low-grade lymphomas, first-line therapy we use are bendamustine and rituximab. For high-grade lymphomas, first-line therapy is R-CHOP. R-CHOP means rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisolone. And for second, third-line high-dose salvage chemotherapy protocols and bone marrow transplant is recommended. Fortunately, we did not come across any patient where we have to go for the second, third-line high-dose salvage chemotherapy. Adjuvant therapy or radiation is involves ISRT, which is involved site radiation therapy for lymphomas are limited to a smaller area, and often it's combined with the chemotherapy. Well, sometimes observation is a choice. There are lymphomas in which initial observation is recommended if the patient is asymptomatic. But in the orbit, we give chemo radiation even in low-grade lymphomas because patients are mostly symptomatic and eye is organ is at rest. So these are now, I will show you some of the pictures. This is the first picture. Just show you how the surgery is technically sometimes challenged because muscles are, extraocular muscles are involved in this lymphomas tend to involve the muscles as well. So this is the pre-op, this is the post-op, but this is the inferior rectus it has been involved, and this is a tumor you can see here. This is a different, this is a Langerhans cell, histiocytosis. This is a tumor. This is a extranodal marginal zone lymphoma, which is quite common, and one of the commonest B-cell lymphomas. Yes, you see this is a pre-op, and this is a post-op, and this is precursor B-cell lymphoblastic because one of the rare tumors, precursor B-cell lymphoblastic. Those are COVID days when the patient they were having COVID in Pakistan. So this is the tumor, and that was then managed by surgery and radiation and chemotherapy. Presentation types, you can see, usually we see the lymphomas like this. It's like tongue-like along the gingiva, then as well as involvement of the orbit. This is a large B-cell lymphoma. This is removed after surgery. This is Burkitt lymphoma, case of Burkitt lymphoma before chemotherapy and after chemotherapy. And this is a large B-cell lymphoma. Again, large B-cell carries a rather not a very good prognosis, but anyway, we removed the case, and then she had chemotherapy, and then she had squint surgery as well to correct her alignment. Systemic presentation, as mentioned, the 10% of the cases have systemic presentation at the time of their presentation. They have 10% will have systemic involvement. This is a bilateral, and she is also having paraspinal lymph nodes as well as mediastinal. Diffuse large B-cell lymphoma, which is also a common B-cell lymphoma. This is a bit rare young patient having this anomaly. And this is reactive hyperplasia, or is a tumor-like. It's not exactly lymphoma, it's a tumor-like B-cell proliferation, predominance of B-cell, but it could be a big tumor as well. So this is a pre and post-op. Reactive. This was rather an unusual case, presented as pterygium. Imaging revealed along the medial rectus, and it came out to be reactive lymphoid hyperplasia, and this was pre-op, and that is post-op. Rosai-Dorfman disease is also one of the hematolymphoid lesions, and bilateral, and there's multiple lesions were removed. Kesselman disease is again, as I mentioned, is a tumor-like lesion with predominant of B cells, bilateral, after surgery and chemotherapy. T-cell lymphoblastic lymphoma, and this is the now important thing is that, as I mentioned earlier, not only we have to have extensive workup right at the beginning, but we have to have a very long follow-up. So this patient was surgery, having removed the surgery. After 7 years, he presented again with eyelid involvement. So the long-term follow-up is very important. Again, this patient, right side lymphoma, and then after 1 year, the second eye also was involved. So which again emphasizes the importance of close and long-term follow-up. In summary, OLs, these ocular adnexal lymphomas comprise 10% of orbital SOLs and Al-Shifa trust series. Wide age range between 2 years to 100 years, marked male predominance, 65% were male. Mature B cell comprises majority of these lesions, surgery and chemotherapy are the major options with very good results. Fortunately, they're quite chemosensitive. Long-term follow-up with repeat systemic workup is essential. Thank you very much.
Thank you so much, sir. Now I request Professor Asad Aslam Khan to present his topic on management of orbital tumors in children, dermoid to rhabdomyosarcomas.
Bismillahirrahmanirrahim. I'm going to talk about orbital lesions in children. I dedicate my talk to my mentor, Professor Muhammad Mirul Haq. My study period was about 29 years from 1996 to 2024 at Institute of Ophthalmology, King Arthur Medical University, Mayo Hospital, Lahore. Orbit, we all know, is a bony cavity. It houses tissue derived from all the three germinal layers. Therefore, a wide variety of tissues, lesions from endoderm, ectoderm, mesoderm, they arise. So we come across a wide variety of orbital lesions. The purpose of this study was to overview the total number and distribution of orbital lesion children managed at Tertiary Care Eye Hospital. Patients were admitted, history was taken, necessary investigations were done, and where necessary, surgical excision was done, histopathology, and later on, if they needed, they were put on chemotherapy or they were put on follow-up. From in 29 years, we had total of 2,811 cases, out of which 583 they left against the medical advice or when they were referred to other departments, ENT, neurosurgery or oncology, and they never came back for follow-up. So I am presenting analysis of 2,228 cases, and out of these, 34% were non-neoplastic and 66% were neoplastic. And among the neoplastic, about 30% were benign and 70% they were malignant. And among these lesions, about 39% they were in children and 61% they were in adults. And we divide the orbital lesion into 4 categories. Primary, the lesions which originate from the tissues of the orbit, including the eyeball. Secondary, which invade the orbit from paranasal sinuses, from eyelids, from nasopharynx or from cranial cavity. Then third category is the hemopoietic reticuloendothelial system, and fourth is the metastatic. Out of these, 81% was primary, 14% they were secondary, 4% they were hemopoietic, and about less than 1% they were metastatic. Amongst the primary orbital, this is the same. Among the primary orbital lesions, the most common they were from the eyeball, 51%, followed by cystic, vascular, inflammatory, muscular, pseudotumors, nervous, peripheral nerve tumor, and so on. Among the paranasal sinuses, among the secondary, 50% were from the paranasal sinuses, 50% from the eyelid, and among the hemopoietic reticuloendothelial, about 66% were lymphomas, non-Hodgkin mainly, and 33% was leukemia. There was one case of Ewing sarcoma. So primary basically they were from retinoblastoma, and they had different modes of presentation, simply from leukocoria to uveitis to squint to fungating mass, proptosis, and finally to fungating mass. So they were different presentation, and the management of these depend upon the time of presentation. If they are limited to the eyeball, so we can go for chemotherapy, transscleral plaque, intraarterial chemotherapy, and there are so many options if the tumor is limited to only to eyeball. But once it is outside the eyeball and invaded the orbit, then we have no option other than to go for excision followed by chemotherapy and radiotherapy. But again, this is for the young postgraduate students, that when you come across a patient of acute proptosis, so not every child is a case of retinoblastoma. Other lesions, they also mimic retinoblastoma, like acute orbital cellulitis, rhabdomyosarcoma, acute hemorrhage in the orbit, they all mimic like retinoblastoma. And if we do not proceed properly, if we proceed without proper investigation, we can go unnecessary loss of the eyeball going for enucleation or exenteration. So this was a case who presented, and when we did CT scan, the eyeball was full of tumor. You can see the eyeball was full of tumor, and this we had to go for exenteration. So another case, it looked like proptosis, but when we investigated, the eyeball was clear of the lesion. So there was some retrobulbar mass. Probably this patient has trauma, but couldn't disclose to the patient parents. So when we operated upon, this turned out to be a large hematic cyst. We drained, and this is a post-operative photo of the same patient. So proper investigation is necessary in each and every case of child presenting with acute proptosis. Among the inflammatory in children, they are mainly the orbital cellulitis and orbital abscess, and few cases of tuberculosis were also seen in children. Acute inflammation, acute proptosis, proper investigation done like CT scan to rule out any intra or extraocular lesion, and the management of these cases is aggressive antibiotic, and if abscess is formed, then we have to go for incision and drainage of the abscess. And these patients, they respond well to aggressive antibiotic. Among the cystic, mainly they were dermoid and few cases of hydrated and chocolate cysts. So they can be either primary arising within the orbit, or they can be secondary orbital cysts from the adjacent sinuses, mainly from the frontal seal. So treatment is surgical excision. Vascular lesion, they are mainly in children, they are capillary hemangioma and cavernous hemangioma. Mostly they are capillary hemangioma. And an intraorbital component along with superficial cutaneous component may coexist in the patient, and in such cases we treat the patient with systemic beta blockers, and they show very good response. In few cases we also go for ultrasonic guided triamcinolone injection, and they also show good response. Is a patient who has both superficial and deep component, and we did intralesional triamcinolone, and this patient responded very well. Cavernous hemangioma, they are usually intracondylar, and our treatment is surgical lateral orbitotomy. Orbital varices, surgical excision, hematoma, surgical excision, surgical management. Optic nerve glioma, they are common in children as compared to adults, where meningioma are common. And in optic nerve glioma, we usually wait till if there is no involvement of invasion of the optic canal, then we usually wait. And if the patient or attendant, they are worried about the cosmetic, then we have to tell the patient that there will be a permanent, although there is loss of vision, but even after surgery, there will be no recovery of the vision. So management of optic nerve glioma is the surgical excision of the tumor. This is the removed eyeball, part of the optic nerve. Nervous tissue neurofibroma. If the neurofibroma is limited to the eyelid, then it is very difficult to excise because they regrow very rigorously, and it's very difficult to reach the roots of the lesion. However, schwannoma, they are well circumscribed and they can be easily removed through lateral orbitotomy. Muscular, the common, the rhabdomyosarcoma, very fatal tumor, and treatment is usually initially would go for surgical debulking followed by chemotherapy, and if there is recurrence, then we have to go for exenteration. Few cases of rhabdomyosarcoma, they present like acute proptosis and mimic like retinoblastoma or orbital cellulitis. Among the osseous, there are osteosarcoma and osteoma, and there are few congenital lesions which cause displacement of the eyeball. They are the encephalocele, polycystic, meningocele, heterotropic, glial tissue, amniotocele. The management of all these congenital lesions is surgical excision. Initially, there is pulsation, but later on, there is segregation from the cranial cavity, so we can easily excise these meningocele and encephalocele. Serotumors, sarcoma, there was blue cell tumor, soft tissue sarcoma, and among the secondary, they were mainly from the paranasal and eyelid, neurofibroma, capillary hemangioma. Management of capillary hemangioma is very promising by the beta blocker or intrarenal canacot. However, surgical excision of neurofibroma is very difficult. Paranasal sinus, they are mainly from the ethmoid and frontoethmoid. The management is, initially we have to control the acute infection with aggressive antibiotic, and then we have to operate upon to drain out the abscess or mucocele formed in the ethmoid sinus, frontal sinus or frontoethmoidal sinus. Hemopoietic, they were mainly lymphomas, non-Hodgkin or leukemias, and they are treated by the oncology department. There is one case of Ewing sarcoma. So in conclusion, whereas retinoblastoma in comparison with the adults, whereas retinoblastoma, rhabdomyosarcoma and optic nerve glioma are common in children, as compared to pleomorphic adenoma, adenocystic carcinoma of lacrimal gland, cavernous hemangioma, optic nerve meningioma, neurofibroma, that they are relatively common in adults. Timely diagnosis through appropriate investigation and prompt management, mostly surgical, of these cases is important to ensure good prognosis for both vision and sight. This is the Institute of Ophthalmology, KE Medical University, where all the study was done. Thank you very much.
Thank you, sir. Now I request Professor Ibrar Hussain to please join us on stage. The topic of his discussion is traumatic orbital hematoma.
Bismillahirrahmanirrahim. Our topic for discussion is orbital hematoma, and I'll discuss few cases, and all of them are due to trauma. Now, this is the case one, in which is a 15-year-old boy. He had trauma to the left eye 11 days back, followed by protrusion of the left eyeball with mild pain. And if you look at the signs, the positive signs are slight decreased vision in the affected eye, left eye, and then there is a 23 millimeter with 3 millimeter inferior dystopia of the affected eye. So there is a protrusion of the eyeball and there is slight decrease in the vision. Otherwise, other signs are normal. Now here you can see the child. This is the left eye, and you can see the inferior dystopia, and you can see here slight proptosis. This is case one. Now here is the CT scan, and you can see an area here, whitish area, which was later, and here you can see more prominently. This is the case 2. 8 years old girl, trauma left eye with a stone, 20 days, protrusion of the left eyeball and pain in the left eye. Now here you can see the signs, the positive signs. There is a marked decrease in vision. There was an corneal ulcer and it was due to exposure keratitis. I'll show you next picture. There was RAPD and there was upward limitation of the movement. Here is the CT scan, and you can see the again collection there, very obvious here. This is the case 3. 14 years old boy, trauma to the right eye with stone, 20 days back, protrusion of the right eyeball with mild pain. Now here this is the another case, the case 3. Case 4 is the last one, 13 years old boy. 13-year-old boy, trauma again with the motorbike accident 6 days back, protrusion of the left eyeball and loss of vision. ये advanced AI है. So this is the case 4. उधर से नहीं तो चेंज करें, मैं कहता हूँ नेक्स्ट बता. Now, coming to differential diagnosis, so in all the 4 cases, the common thing was trauma, proptosis, and dystopia. In most of the cases, there was dystopia as well. Now, what we were thinking, what differential diagnoses come in our mind are orbital cellulitis, rhabdomyosarcoma, carotid cavernous fistula, acute leukemias, orbital hematomas. These are different things which comes in mind. Metastatic neuroblastoma in children, lymphangioma, histiocytosis X, and Burkitt lymphoma. So many diagnoses. But if you look at the history, it was trauma and proptosis. So it was a orbital hematoma, and let us see what happened next. Now, what is the treatment choice? We'll see the video as well. Now, general measures exclude injuries to the other parts, especially the head injury. Stop anticoagulants and aspirin, etc. after consultation with internist. Mild orbital hematomas with no pressure on the optic nerve you can observe. Many resolve spontaneously. And larger orbital hematomas cause pressure on the optic nerve and or significant proptosis, which were there in all these cases. So what are the options available? Lateral canthotomy and cantholysis and evacuation. Now ये वीडियो है यार, चलाएं उधर से. Now this was the case 1. You can see the proptosis and inferior dystopia as well. Now we pointed out the lesion on CT scan and then put the needle, and you can see the aspiration of blood. So about 7 to 8 cc of blood was sucked out. You can see here. Now this is immediately post-op. You can see there is no proptosis and there is no dystopia. Now this is pre-op and then post-op after the removal of the blood. This is the second case. You can see about 6 cc's of blood was drained out, and you can see the result. This immediately after the removal of the blood. This is case 3. Again, about 4 cc of blood was removed, and the proptosis was not there immediately after the aspiration. And this is the last case 4, case 4, where you can see the result. This is after 1 week. Little blood was aspirated as compared to the other cases. So orbital hematoma is defined as a collection of blood inside the orbit behind the orbital septum. It is extraconal, or it could be intraconal or subperiosteal. Causes will not go into detail, but trauma is at the top. Signs we have already discussed. Investigations, imaging studies are very important. CT, MRI, or B-scan. Blood coagulation profile is needed, and then the CBC with ESR. Treatment, general measures, intravenous antibiotics, systemic steroids if indicated. If there is a pressure on the optic nerve and there is a edema, then we can think about systemic steroids. Needle evacuation, ultrasound guided if facilities available, orbitotomy in selected cases, and treatment of exposure keratitis if there. Thank you very much.
Thank you so much, sir, for very interesting cases. Now I request Brigadier Amir Yaqub to please join us on stage. His talk is on the topic of intraconal orbital tumors.
Right. So I've been asked to talk about intraconal orbital tumors. Some of the things have been already covered, but I'll briefly go through what I've come across during my career. So briefly, intracoronal space is the space enclosed by the forerecti muscle and includes the optic nerve and all the usual tissues like blood vessels, nerves, and the main portion of that area is the orbital fat. Most of the tumors in the intracoronal region are primary orbital tumors and include the optic nerve glioma, optic nerve sheath meningioma, which may be malignant, vascular tumors, rhabdomyosarcomas, lymphomas, and primary orbital melanomas. So we go through each briefly. Optic nerve gliomas are common tumors of childhood, and they present as axial proptosis. Usually they are limited to the orbit, but they can grow through the optic canal into the intracranial region, and that can cause nystagmus, spasmus nutans, seizures, hydrocephalus, and endocrine abnormalities. So CT and MRI are very elaborately delineate them and show you the intracranial enlargement extension if there is there. Conservative management is done till the vision is there, or if there is intracranial involvement. Surgery is generally reserved for patients who have cosmetically disfiguring proptosis or massive corneal exposure. Optic nerve sheath meningiomas are slow-growing benign tumors occurring in middle-aged ladies mostly, and they arise from the optic nerve sheath. They present slowly with progressive vision loss, visual field defects, and loss of color vision. And they generally, the classic triad is proptosis, vision loss, and opticociliary blood vessels. Radiotherapy is useful for slowing the progression, but the overall response to treatment is poor, and surgery obviously runs the risk of loss of vision. Lymphoproliferative tumors can occur in any part of the orbit, and they are generally occur in the extracorneal region. But recently I came across a 38-year-old gentleman who presented with an intracorneal mass, and I suspected that it might be a cavernous hemangioma. I observed it for about 2 or 3 years, and it was gradually increasing in size. So I went ahead and removed it. You can see the optic nerve separately from the tumor in the axial sections, and this turned out to be a marginal zone lymphoma. Vascular tumors, the most common one is the cavernous hemangioma. Others like hemangiopericytoma and varices can also occur in the intracoronal region. This gentleman presented with a massive proptosis on the left side with the hugely bulging eye. Generally, they present between the ages of 20 and 40. They are well encapsulated, slow-growing tumors, and they are generally amenable to complete surgical excision. So this is the imaging of this gentleman, and this is the after removal of the tumor. Myogenic tumors like rhabdomyosarcoma generally present in childhood and can present as intracoronal masses and axial proptosis. These are classified into embryonal, alveolar, pleomorphic, and botryte subtypes. In imaging, they present as a well-circumscribed, irregular, and relatively homogeneous mass within the orbital soft tissues. Management consists of surgical biopsy, debulking, followed by systemic chemotherapy. Primary melanocytic tumors are rare, but they are very malignant, and generally they occur in the arise from the uvea, but occasionally they arise from the orbit as well. The tumor generally presents as a relatively progressive and well-defined mass. An anterior orbitotomy and biopsy is done to confirm the diagnosis, and once it is confirmed, then orbital radiotherapy is helpful, or you may go for exentration. Peripheral nerve tumors like schwannomas and neurofibromas can occur in the intracoronal region as well. And these are again benign tumors, slow growing, but arise away from the optic nerve, not from the optic nerve itself. And they arise usually between the ages of 20 to 60 years, and some of them are associated with neurofibromatosis. So once you're confronted with a patient with an orbital tumor, you diagnose them mainly clinically and by imaging, and these generally give you a presumptive diagnosis, which needs to be confirmed either by a biopsy, which can be incisional or excisional. Excisional biopsies are useful for well circumscribed and well demarcated and encapsulated tumors. For malignant lesions, biopsy is used to confirm the diagnosis, and then you plan either chemotherapy or radiotherapy. Surgically, you can approach the intracoronal tumors either from a lateral canthotomy incision. Previously, we used to use the classic Stellard's lateral orbitotomy, but now I think fewer patients, doctors are using this. You usually make a lateral canthotomy, and you can approach the lateral part of the intracoronal space easily through that. For medial intracoronal tumors, you approach either through a Lynch incision or through a transconjunctival or transcaruncular incision. The choice of approach depends on the location of the tumor and size and extent of the tumor and the suspected pathology. So in conclusion, clinical presentation is essentially informing a differential diagnosis and guiding further investigation. Imaging has revolutionized the diagnosis of orbital tumors, and when combined with orbital examination, we can usually make a good guess what the tumor is. But when in doubt, biopsy is mandatory, and a choice of surgical approach is critical in avoiding injury to orbital structures while obtaining adequate tissue from the orbit. Thank you very much.
Thank you so much, sir. Now I request respected Professor Dr. Imran Akram Sahab to please join us on stage. The topic of his presentation is exposure keratopathy management in proptosed eye.
Bismillahirrahmanirrahim. Assalamu alaikum. I'm going to talk about how to prevent exposure of the eye and exposure keratopathy in a patient who has got a marked proptosis and is unable to close his eyes for any reason. Now, physiologically, the cornea derives its water supply from a tear film and is constantly spread over the cornea by the lids. In exposure keratopathy, whenever there is extreme exposure, the tear film is not spread for any reason, and the epithelium gets desiccated and shed off. Once it gets desiccated and shed off, the barrier is broken and the pathogens can easily invade the cornea. There are many causes of dryness or inadequate spread of the tear film, and one of them is abnormal glow position of proptosis, extreme degree of proptosis. Now, the pathogens having collagenase, they can invade the cornea and melt it, resulting in desmetosebum perforation and infection of the globe. So there are many associated clinical features and which tell you that the exposure is taking place. And it is such a sensitive matter. Even if you don't put enough water on the cornea during corneal cataract surgery, just a few minutes and you will see the color of the epithelium changing. So it's such a sensitive matter. So the exposure in proptosis is, for simple reason, there is restricted eye movements, and sometimes the eyeball is just protruding beyond the lid aperture. So how to manage the exposure in a patient of proptosis? You can have medical management, just like lubricants, ointments, Then we have got surgical management. Surgical includes that we can do tarsarethy, but not in all the patients. And then, well, if we treat the proptosis itself, the danger is eliminated. Now, well, with the medical treatment, lubricants are drying up every few minutes. And if you just put the ointment just to please yourself, otherwise the ointment just moves away with blinking. And the cornea is again exposed. And tarsorrhaphy may not be possible in large proptosis. Now, mostly it's a waiting period which is important. You are not operating on every patient of proptosis for different reasons. It could be medical and otherwise. And even in some patients like thyroid or autoimmune diseases, you don't operate and the proptosis remains for long periods of time. So the management in an intermediate period is what we call the wet chamber or wet goggles. The concept of wet chamber comes from, if you see, this is a beaker of water, and the molecules of water are just escaping all the time and they are not returning. So there's constant outflow of the molecules. But if you just cover the beaker, then as the molecules escape, they start also coming back. And after some times, there is a balance between the two. And no more net amount of water is escaping. So this is the theory behind the wet chamber. So no more evaporation, net evaporation of water is taking place. Well, wet chamber for proptos, I may provide protection over prolonged periods, but there are certain problems. For example, using wet chamber goggles and likewise, they've got disadvantages. Can't be used during sleep, and patients who are uncooperative, moribund patients or children, they can't wear that for long periods and they're quite uncomfortable. So we devised a method of creating a wet chamber, which is a novel method in prolonged periods of exposure. It's a very simple one. It can be used not only in proptosis, can be used in so many other conditions like traumatic colobomata and other conditions, where we use a cellophane membrane to create a mini wet chamber in front of the eye. We just need an offside sheet, a dressing kit, and some ointment. The method is very simple. You just clean the area around the eyeball, you make it dry, and cover the eye with the ointment, not the surrounding area. You cover the eye with the ointment, and you just apply the opsite. So this is a patient, and we are just stretching the opsite sheet over him, over his eyes, and there you can see we have applied the opsite. Now, the little area air between the opsite and the eyeball, that becomes saturated with water, and there is no more net evaporation of the water molecules, and so the epithelium does not get dry. It's very easy to apply, very handy to do. That's what it is. This is one patient who's moribund and he's got he's got head injury and he's got an exposed eyeball. And it's not easy to operate on him because the general anesthesia can't be given. So there are ideal situations where you can apply the wet chamber. The advantages, a lot of advantages, easily available, it's convenient, and it can be used during sleep, and it can also be used in uncooperative patients. you do need changing the offside a few days, more so in the summer, and sometimes infection inside may not be obvious because of the silicone sheet reaction. But it's an easy and effective way of covering the eye. We have been using this method not only in the proptos patient, when I was especially in the general hospital, there were a lot of patients coming like that. And we are using them in the neurosurgical cases and even in the children who come with colobomata. And it's so easy to learn and it can be practiced everywhere. The cellophane sheet or offset is available everywhere. Thank you very much.
Thank you so much, sir. Next, I invite our foreign guest, Mr. Ken Osterker, to please join us on stage. The topic of his discussion will be orbital blowout fractures: when, what, and how to repair.
Okay, so good afternoon, everybody. First of all, I want to thank Ophthalmological Society of Pakistan for this kind invitation. It's a pleasure and honor for me to be here. And we know that the connection between our countries and people is very old. In our capital city of Ankara, we have a very prestigious and popular street named after Jinnah, and you have one in Islamabad named after Atatürk. And people around my age in Turkey remember very well, we have one international children's celebration festival every year, and people all around the world, children all around the world are coming. And it's a very good memory for us that children from Pakistan were coming and singing the song Jive Jive Pakistan, which was a favorite melody for us. And we were always told that Pakistan is our brother country. And I had the chance to experience this brotherhood when I was doing my fellowship with Dr. Yasir Khan in Toronto. And Dr. Khan himself, his family, and all the people from the Pakistani community in Toronto that we had the chance to meet with were there for us whenever we needed. So I'm very happy to be here, and I'm hoping to meet new friends and colleagues here from Pakistan. So the first topic is about orbital blowout fractures. Unfortunately, there is not evidence-based data enough due to the lack of randomized controlled trials in this field, and we don't have any good guidelines that can lead us. So there's too much controversy, and I will try to focus on when to operate and what to repair. But before I start, there's one point where there's no controversy about. It's that the trapdoor fractures that we see in children and young adults are true emergencies, and they need to be repaired as soon as possible when we see them, preferably within 24 and 48 hours. So I will start with the second question first, what to repair. The classical indications for repair are anophthalmos and diplopia. For anophthalmos, when I was a resident, it was taught us if the fracture is on the CT scan larger than half of the floor, that needs to be repaired because there will be a late anophthalmos. There are also more specific measurements based on CAT scans measuring the height of the displaced orbital tissue or increase in orbital volume. But unfortunately, there's no consensus on clinical and radiological signs to predict the final anophthalmos that the patients will have. So each patient is individual, and we don't know how they will heal. We don't know how much late fibrosis or late fat atrophy they will have. And there's a study from 2017 by Young et al. Based on CT scans that showed in patients with not very large fractures, but medium to small size fractures, during the follow-up without any treatment, there was spontaneous healing in more than 90% of patients, probably related to reformation of periorbita and the bone. So this was a patient referred to me as a highly intellectual 74-year-old lady, came to me 2 weeks after the injury with left side orbital fracture. And when I saw the patient had on the CAT scan a really large fracture involving the medial wall and the floor. But at the presentation, the swelling was gone, and she didn't have any severe enophthalmos from the beginning, and she had no diplopia. So I decided to wait on her case, and 3 months after, there was no diplopia still, and the enophthalmos was the same, less than 2 millimeters. So she survived the problem without any surgery. And you can see that 4 months after the injury, although this is not a CAT scan on the follow-up, there's a slight improvement on the orbital floor fracture, which shows us spontaneous healing. Also, it's important how much the patient will accept the enophthalmos, because each patient is different. This patient came to me during the time of pandemic, and we were not able to do any elective surgeries during that time. And he had a very small enophthalmos, in fact. Yes, more than 2 millimeters, but not more than 3. And his main complaint was the asymmetry on the lid crease. So I wanted to see his old pictures before the injury, and when we looked at them together, we saw that the asymmetry was already there before the injury. And I told him that the surgery to repair the floor may not correct his asymmetry. So he was okay, fine with that. And 4 months later, the asymmetry was the same, and the patient was happy. There was no progression in his enophthalmos. So what about diplopia? A study from 2012 shows us that 20% of floor fractures and 10% of floor fractures present with diplopia. So most of them don't have diplopia in the beginning at all. And also a recent ASOPERS data from 2024 showed in more than 300 cases, only 20% patients had diplopia at the beginning. And during the follow-up, there was no new diplopia, and more than half of the patients with the diplopia had spontaneous resolution within weeks. So according to that, this means most isolated blowout fractures do not require any surgery. And then let's go back to the first question. If they do need surgery, when should we do that? Once again, when I was a resident, the classical teaching was based on the study from Bernstein from 2002. The fractures with symptomatic diplopia and large orbital floor fractures needed surgery within 2 weeks. But the problem is the 14 days waiting period is too short for a trapdoor fracture, and also too soon to be able to see a possible spontaneous resolution in these patients. In the last 15 years, there have been many studies that show that late surgery can be as successful as an early surgery. Even surgery 6 weeks beyond can have successful functional and cosmetic results. This was another patient referred to me, 24 years old, came to me 4 months after the injury. He went to many different doctors, and he was complaining about enophthalmos and lid crease asymmetry on the left side. And 8 months after the surgery, the enophthalmos was successfully corrected with less than 2 millimeter difference between both sides. Another patient came to me after being repaired by a plastic surgeon 2 months before, and he was referred to me by the strabismologist because they were planning to do squint surgery, but first the enophthalmos had to be corrected. And when I checked the CAT scan, I could see that the orbital implant was not covering the inframedial part of the orbit and also not the posterior part. So what I did, I removed the implant and replaced it with polysporyethylene implants. And finally, the enophthalmos was corrected. 3 months after the surgery, you can see the difference. And the patient had still diplopia and needed to have strabismus surgery. And you can see the postoperative CAT scan after the second surgery. So the answer when to repair is, in patients without obvious muscle entrapment, we can wait as long as diplopia keeps improving, and it typically resolves spontaneously. Late enophthalmos is very rare, and late repair can be pursued if necessary. The surgery can be safely delayed for at least 6 to 8 weeks, as long as we work meticulously and patiently to release all the tissues and repair the fracture. So the last question, how to repair? I use This is a trapdoor patient, a young patient with right orbital floor fracture. And I use swinging lower eyelid approach. After doing a cantotomy and cantolysis, I make a preseptal dissection, reach the orbital rim. Make my incision on the periosteum, and then detach the periosteum to reach the orbital floor and see the fracture. So you can see the fracture here. As this was a trapdoor fracture, this was a fresh case. And it's important to remove gently and meticulously all the trapped tissues out of the fractured site. And it's very important to see all the borders of the fractured area. And then we need to trim our implant and replace it, completely covering the fractured site. And then we close it up, and the force reduction test was negative at the end of the surgery. So, as take-home message, I can say trapdoor fractures are true emergencies that shouldn't be missed. And the other cases will most likely not require any surgery, and we can observe them for 6 to 8 weeks before doing any repair. So decision for surgery is not just based on the functional symptoms, also on the expectations of the patient. And during the surgery, we have to be sure that we have exposed all the borders of the defect, especially the posterior border, and customize the implant so that all the borders of the defect is covered, and place the implant on the posterior bony ledge. Otherwise, we will get enophthalmos after the surgery. So thank you.
Thank you so much. This was a very enlightening talk, and I hope our hospitality is treating you well and you will take away wonderful memories from here.
Dr. Ehsan is a son of late Professor Muhammad Mirul Haq Sahab, and he is a very fine and renowned maxillofacial surgeon working as Associate Professor Maxillofacial at King Edward Medical University. This session is named after his father, Professor Muhammad Mirul Haq Sahab.
Bismillahirrahmanirrahim. I'm sorry for my voice. Actually, I just reached from Karachi and I have high-grade fever in the morning, but I did not wanted to miss this session. Good evening, everyone. It's an immense pleasure and honor for me to be here today at this prestigious ophthalmology conference. Today I am presenting a comparative clinical study evaluating two approaches to the orbital floor reconstruction: conventional versus endoscopic assisted repair. I briefly go through background, technique, some outcomes, complications, and recommendations on my clinical experience. As you know that orbital floor fractures form up to about 30 to 40% of the midfacial trauma. The main goal of the repair is to restore orbital volume and ocular function. Endoscopic repair is gaining popularity due to its minimal access, and it has a benefit that excellent visualization through the antral antrum. We can see all the contents have been retrieved or not. A study was conducted in 2024. We have taken 15 patients for each group. 15 were treated with endoscope, assisted surgery, and 15 were with the conventional methods. And we have seen the parameters of operative anophthalmos, intraorbital nerve recovery, operative time, and complications. As you know, such kind of fractures can be seen through the trapdoor sign. CT scan is showing blowout fracture and inferior displacement of the content into the antrum. So we reconstruct this through the conventional methods, through the incisions, infraorbital, mid-tarsal, subciliary incisions. These are the conventional methods. And by the endoscopic methods, we do reconstruct with the same, we have to give the incision, but visualization of the defect through the antrum through endoscope. So mostly we find the cases with road traffic accident, they comprises of about 75% patients. So these are standard incisions, subciliary, mid-tarsal, infraorbital, and transconjunctival incisions. But if we have to go through the endoscopic approach, we normally prefer to go through transconjunctival approaches and visualization of the orbital content through the antrum through the endoscope. As you see in this picture, the main advantages are predictable access and the ability to manipulate extensive defects confidently. However, it does come with the limitations, particularly the risk of lower lid complications such as scarring or retraction. So this was the case, operated a patient for mucormycosis, where the infraorbital rim was also removed along with the floor of the orbit. Extensive disease debridement was done, and you can see a displacement of the eyeball downwards, and there was no bony support. So reconstruction was done through the conventional method, through the previously given incision. Titanium mesh was placed, which has served the dual purpose, and it made the floor of the orbit as well as the rim of the orbit, and you can see some acceptable results. This case represents a different clinical scenario where orbital reconstruction was not performed in the traditional sense. The patient required a complete orbital excision due to aggressive tumor involving the orbital contents. The focus was to achieve oncological clearance while preserving the surrounding structures such as much as possible. Although this doesn't fall under the typical fracture repair, it demonstrates the extent of the surgical exposure and anatomical access achievable through a conventional approach. Post-operatively, the goal was to prepare the patient for prosthetic rehabilitation. This case highlights the range of the orbital surgeries we encounter in such cases. So sometimes we find the cases like this, a firearm injury case, unfortunate patient damaged both of his eyes, and but he needs a repair of the orbits due to the prosthetic eye requirement in the future. And another method, 3D reconstruction. Sometime we made ST models, stereolithographic models, which we pre-bended the titanium mesh in it. They do for us the mirror image to the intact side, and we adopt the titanium mesh over there and then place in the patient. Another case, this is a prosthetic eye on his right side, followed by orbital repair. He got this prosthetic eye. His eye was injured in the road traffic accident. Sometimes we find the cases with hemifacial microsomia, congenital deformities, and here we have done malar implant as well as orbital floor repair. But as long as we considered the endoscopic approach, I normally prefer to use 0 degree, 4 millimeter diameter rigid straight endoscope through the transantral approach. This is a case which was done with the endoscopic as well as the open for the fractures, a road traffic accident where the orbital floor was, the content was retrieved through the endoscope, it was visualized, and here in this small video.
Camera roll action.
अच्छा back into the orbit, you can see that there is a and now and hence we make sure that it is very hard to posteriorly the contact they remain in the sinus. So endoscopic repair is an excellent minimally invasive alternative with strong clinical outcomes. Conventional repair remains indispensable for extensive fractures. Thank you very much.
Thank you very much, Dr. Hassan. The last talk in this hall is by Professor Sophia Iqbal. So by our apologies in advance. We are short of time that we have to hold plenary session in this hall. The last two talks will be in Hall A. So I request Professor Sophia that although I took 2 more minutes, but I request you to please finish in time.
Well, I will start with my talk that is about pediatric orbital pathologies. I'm going to discuss a few which I have managed in the last few months. So we all know that orbit is a very small space which has got a variety of pathologies like developmental, inflammatory, traumatic. So surgical management must balance vision, cosmesis and function. The cases which we have managed, we will share them, the diagnostic dilemmas, challenges and the clinical pearls which we encountered. This first case was a child who was a 5-year-old male child with mild proptosis and dystropia for 4 weeks. There was no visible sign of trauma, no history of trauma. Only the disc was hyperemic, and as can I get a pointer, please? Yeah, you can see that there is a mass, but there is a fluid level as well, and it was well encapsulated. So we decided to do an anterior orbitotomy and remove that. It was a well encapsulated, thick capsuled structure, which turned out to be an orbital subperiosteal hematoma. This is a very rare entity, and in children, you know that the periosteum is not very tightly attached except at the rims. So the fragile emissary vein here can bleed and lead to this condition. So remember that children, the history may not be there, the obvious sign may not be there, and this is very important not to miss because they are at risk of amblyopia. The second case was a 3-year-old healthy female child with a right eye swelling since birth, which kept on progressing and it kept on involving the entire eye. The left eye, on the other hand, was microphthalmic with coloboma of the iris and the lens. This was the B scan of the left eye. You can see a small eye with 2 small cysts, and in the right eye, there was a very huge cyst. So this was the MRI findings, and you can see quite a big lesion over there, and there was calcification in the globe. This patient was advised exenteration because of this calcification. So we decided to explore it because the other eye had microphthalmia, the other eye had pathologies, and the history was very long, so we were not suspecting retinoblastoma. So we explored that, and there was a big cyst there, and the microphthalmic eye was eviscerated with a small implant and a scleral shell placed. We were able to place the shell because the expansion of the orbit was taking place because of this cyst. This was another case which we reported, and this is actually a microphthalmia with an orbital cyst. So what exactly is this? It's a developmental anomaly. In this, there is a small globe associated with cyst on the inferior side. Why does this cyst develop? Because by 8th week of gestation, when the optical vesicle invaginates to form a cup, it should close on the inferior side, and failure of closure leads to an coloboma. If it is large, there can be outpouching, and there is a cyst which keeps on growing. So this is the imaging. which is very important because you need to know about the connection of the cyst with the optic nerve. You need to exclude encephalocele hair. So treatment depends on the size, potential and orbital volume. In our case, we removed the cyst and because it was quite big, and we put an evisceration with ball implant, but you can do marsupialization and hydrogel implants can be placed. The third case was this 13-year-old female who was otherwise fit and healthy, and with this proptosis and dystopia, and the optic nerve head was swollen. This was a mass, so it looked like a very, very aggressive tumor. We did a supromedial orbitotomy, removed the mass, and it turned out to be a benign, rare mesenchymal tumor, plexiform fibrohistocystic tumor, which has very low-grade malignant potential, but it's better to excise it completely to avoid the risk of recurrence. The fourth case was a 7-month-old male child with a proptosis for a few weeks, and it kept on increasing for the last 6 months. No increase on Valsalva maneuver. This was the scan, and our differential was infectious, inflammation, neurogenic and mesenchymal. This was the MR finding. You can see a complex over here going posteriorly backward as well. So on exploration, it turned out to be very encapsulated lesion, and when we sent it for histopathology, it turned out to be a cavernous hemangioma, which is very, very rare in pediatric group. The commonest one is capillary hemangioma. Cavernous is usually intraconal, never extraconal, but in this case, it was not only extraconal, but it was there in a pediatric age group. So we need to keep this in mind. The last case was a 5-year-old female child who presented with pain on eye movements on the left side. There was no proptosis, nothing else. The scan revealed this finding. Inside the muscle, you can see a well-defined structure there. We thought it could be a foreign body there, and then we explored it, but it turned out to be a hydatid cyst. Normally, hydatid cyst does not happen inside the muscle. Normally, they happen intraconally, and they usually present with proptosis. But in this case, it presents on pain with eye movements. There was no visible proptosis there, and the only findings was just congestion on the medial side. So keep this in mind that it can present in an unusual form as well. So the take home here is that a pediatric orbit has a wide spectrum of pathology which can be common but never trivial, and tailored management required for each case. Early intervention can prevent vision loss and disfigurement. Thank you very much.
Thank you very much, Professor Sophia. I think that brings us to the end of this session. Thanks. Because we have to, the next session is, we are already over. We have spent a lot of our time, and it's difficult for the next session to start in time. So we cut short this session, and that brings an end to this session. Thank you very much.